Good afternoon and welcome, everyone. I'm Randy Conley. I'm chair of the Women's Leadership Council at Lahey. On behalf of the WLC, I want to thank you for joining us for this Women's Leadership Council lecture series event. It's time you knew the power of your choices in prevention of women's cancer. We're thrilled to have over 200 of you joining us today to hear from Dr. Valena Wright, Interim Chair of the Division of Gynecology at Lahey Hospital and Medical Center. Today's event is being recorded. With the exception of our speakers, all of our virtual audience members are muted and we won't see you. But we invite you to participate through the Q&A feature at the end, and the polls will take throughout the session today. WLC member and retired Lahey anesthesiologist, Dr. Sarah Davies, will moderate the Q&A session at the end of the presentation. Today's event is in honor of our beloved former Women's Leadership Council co-chair, Kathy Huber, who passed away in July after a courageous battle with cancer that she fought with everything she had. Through her healthcare journey, Kathy learned from Dr. Wright that she didn't have information early on about what symptoms to look for or what to discuss with her healthcare providers. Kathy became passionate about sharing what she learned from Dr. Wright with the community to ensure that all women have this vital information and can advocate for their own care. Kathy was enormously proud of the WLC annual lecture series, which aims to empower women in making healthcare decisions. She took pride in the efforts of our members and events that have raised more than $5 million for Lahey's patients and caregivers. We are proud to honor her by dedicating today's event to her. While there is no effort that can replace Kathy's tangible contributions to Lahey, we have worked hard to create a fitting way that will fuel her legacy of empowering and educating women, and this time about a shared cause, our health. I am very, very proud to tell you today that we have established the Kathy Huber Fund to support the Division of Gynecology at LHMC and provide Dr. Wright with resources to enhance women's health. Support from this fund will help to purchase equipment, to fund educational or research initiatives focused on improving clinical care, or to help educate, empower, and inspire patients to take preventive measures that improve health outcomes. We hope you'll consider joining us in making a gift to support the Kathy Huber Fund. You can make a gift online or by reaching out to anyone on the Lahey philanthropy team. And we thank you in advance for your partnership and support of our and Lahey's efforts. Now, I am pleased to introduce Dr. Valena Wright, Interim Chair of the Division of Gynecology at Lahey Hospital and Medical Center. Dr. Wright is a board-certified gynecologic oncologist with more than 25 years experience in clinical practice dedicated to improving women's health. Her passion for reducing preventable women's cancer led her to author the book, It's Time You Knew, The Power of Your Choices to Prevent Women's Cancer. This book was shared widely by Kathy, who felt that all women should learn this important information, and my copy was a gift from Kathy. Dr. Wright, thank you for leading what I'm sure is going to be an insightful and meaningful presentation today.
Thank you, Randy, for the kind introduction. I'm incredibly honored to be able to speak as part of the lecture series for the Women's Leadership Council. And I had such a privilege to be involved as part of Kathy's healthcare team. She was an incredible woman, brave, courageous, and of all the patients I've cared for, I think she really has probably inspired me the most, because after her visits with me, she would, no matter what was going on, and it wasn't easy for her, she would ask me what I needed. And for me, as a GYN oncologist, it's really sad sometimes, because I'm a GYN oncologist and I see patients after they've been diagnosed, and often the diagnoses are delayed. So it inspired me to advocate more for women and empower women to have choices in their healthcare, to be proactive, to know what some of the symptoms of gynecologic cancers are and how and what to do about them. So let me just share my screen. So all women are at risk for gynecologic cancer. And when we refer to gynecologic cancers in the United States, it's the reproductive organs, it excludes breast cancer. So there has to be even a language that we use and are familiar to be able to start the conversation. So we're referring to ovarian, fallopian tube, peritoneal cancers, uterine, cervix, vaginal, and vulvar cancers. Knowing the symptoms of these cancers is critical. In the United States, every 6 minutes, a woman is diagnosed given a new diagnosis of a gynecologic cancer. And of the gynecologic cancers that occur, only one of those has a screening test. So our model of care is really not on prevention, but on disease. It's a disease-based model. And if you don't know the symptoms, and if you don't speak up, in theory, your cancer is not going to be diagnosed at an early stage when it's most treatable. And I firmly believe that prevention is always better than having treatment and a cancer diagnosis. So this weekend I was cycling on the Cape, and at Duxbury Beach, there's this warning sign. And I thought, this is like so effective. It's right on the boardwalk before you go to the ocean for your swim. It's data driven. You can see the bar graph in the lower part of the, I don't know if you have the whole slide there. You can see the bar graph here in the lower part of the slide that is based on tagging of white sharks off the Atlantic coast. And it tells you, know your risk when entering the water. So it's very timely. It's right there. The information is there when you need it. And of course, there's also the wording in the upper corner, in emergency, call 911. So if you have, I don't know how you would be able to call that, but it does point out that there's a community, and it's important to call 911 when things are difficult. What's the chance of a shark bite? If you Google it, it's about 1 in 3.7 million. You're more likely to die of selfies where you inadvertently fall taking a selfie in what you think is this amazing photo than you are to die of a shark bite. Yet for women's cancer, we don't really have effective public service announcements or advocacy yet for many of the gynecologic cancers. In some of the interviews related to my book, the interviewee would say, we've never had a speaker speak about gynecologic cancers before, which is really a shame. And again, the motivation for my talk today and why we're here. So the 3 main points are to know your risk. If you see something, say something. So if you feel something, if you have symptoms, you have to speak up. It's never a good idea to deny symptoms. We all do it at different times for a variety of reasons. But in general, with cancer, the earlier you have a symptom evaluated, the more likely it will be resolved. And chances are it's not a cancer diagnosis. It's a differential diagnosis at that point. It's a symptom, it's not a diagnosis. So it's really important to seek medical care when you know there's something that's not right. And then finally, the third topic is shots in the arms or vaccinations. We're fortunate in women's cancer that we do have a vaccination that prevents cancer. It's remarkable, yet less than 50%, 56% of US women and men that qualify have received the vaccination. So I wanted to start with ovarian cancer because it's the most deadly of all the gynecologic cancers. Often women have a delay of up to 18 months prior to the diagnosis of ovarian cancer. And when I say ovarian cancer, I'm actually referring to ovarian cancer, fallopian tube, and primary peritoneal, but I'll just summarize it with ovarian because the symptoms and treatments are identical. So ovarian cancer was often called the silent killer, and advocacy groups argued that no, it's not a silent killer, but there are symptoms, and based on national survey of patients, guidelines were developed to try and raise awareness of this. So the symptoms that are somewhat nonspecific are bloating, early satiety, urinary frequency, or bowel changes. When those symptoms persist more than 2 weeks and it's a change from your baseline, you should consider seeing your primary care physician to have them further evaluated. I think one of the biggest problems in diagnosing is ovarian cancer is it's a disease that affects women generally after menopause. And once women go through menopause and they're not having children and they're not seeing an obstetrician gynecologist, it's kind of ignored. And of the women who do develop ovarian cancer, only 25% of those women actually have gynecologic symptoms. Gynecologic symptoms, sorry. The real challenge with ovarian cancer is that there is no effective screening test for the general population. You may have read about CA-125, which is a tumor marker in the blood that can be used to follow patients with a diagnosis of ovarian cancer in response to treatment. But despite years of research and algorithms incorporating CA-125, and in addition to ultrasound as screening, there's never been a study that has shown that CA-125 and ultrasound decreases the mortality rate of ovarian cancer. And in fact, when we screen, we have to be very careful, because if we have a positive test that leads to an intervention such as surgery, surgery is not without its side effects, and having unnecessary surgery or complications of surgery is really one of the issues in screening at this point. So in summary, ovarian cancer generally affects women after menopause. It can be hard to diagnose, but there are symptoms if you pay attention to your body. And when you go to the doctor, if the doctors dismiss you, often the differential diagnosis in this large survey of the diagnosis women were given when they showed up with these symptoms were depression, irritable bowel syndrome, stress, anxiety, gastritis. And when that's the first diagnosis and it lands on your chart, it's hard to get that diagnosis off. And so what do you do? If your symptoms are persistent and the tests are negative that your doctors have ordered, and the most common tests that get ordered are endoscopy, colonoscopies, upper GIs, because many of the symptoms do, sorry, I'm just talking about the beeper. Many of the symptoms do point to an origin somewhere in the GI tract, but you have to just ask and say, well, could this be ovarian cancer, so that the doctor can have a conversation with you to see if ordering a pelvic ultrasound is reasonable, or even a CA-125. It's different to order those tests in screening in the population versus a diagnostic test. It's not unreasonable if people have the syndrome of symptoms with the bloating, early satiety, and you don't have a diagnosis, to ask your doctor to consider ordering an ultrasound or CA-125. And again, I think one of the most common problems I see when women end up in my office is, well, I thought it was just menopause. I was tired. I had children to take care of, older parents to take care of. It's a time when many women have a lot on their plate besides taking care of themselves. And often their own health care is sometimes put on the sidelines to take care of their children or aging parents. So know your risk. Family history is really important for ovarian cancer. Any woman with a personal history of epithelial ovarian cancer should be offered genetic testing or counseling. Even if you have a first-degree relative with ovarian cancer who has a documented gene mutation, you would also qualify for testing on the basis of what we refer to as cascade testing. Because if your first-degree relative is affected, there's a fairly significant chance you could carry that gene mutation as well. So it's important to have the conversations and know and ask the questions. It's not good enough just to have, oh, my grandmom died of a cancer in the women's area, because the risk factors are different depending on the origin of the cancer, and the gene mutations also differ as well. What we did learn about familial ovarian cancer, the most common genes are the BRCA1 and BRCA2. In studying women with those gene mutations who chose to undergo risk-reducing surgery, and if I don't know if you can see my arrow, I don't think you can if I do that. But if you choose to undergo risk-reducing surgery with removal of both the ovaries and fallopian tubes, it was discovered that a lot of what we call ovarian cancer actually originates in the fimbriated end of the fallopian tubes. So cancer cells on the end of the fallopian tube spill into the peritoneal cavity, most often landing on the ovary and creating a larger tumor mass there that we then call ovarian cancer. But for the most common type of ovarian cancer, which is the serous cell type, it's actually often originating in the fallopian tube. So we knew from epidemiologic studies that women who had had a tubal ligation had a lower risk of ovarian cancer than those that didn't. We now know the reason or explanation, pathophysiology behind that. And so for women who have finished completing childbearing, had opted to have a tubal ligation, we no longer do tubal ligation. We actually remove the entire tube in the fimbriated end. And there's very good data from more than 5 years out now to show that removing the fallopian tubes has no impact on when a woman would go through menopause. A lot of women are reluctant to undergo risk-reducing surgery with the fallopian tubes and ovaries being removed because of the risk factors of premature surgical menopause. We know that when women have the ovaries removed prematurely, they have an increase, what we call a 10% increase in all-cause mortality, meaning death from other reasons. And the majority of deaths in women who have tubes and ovaries removed early is attributed to the increased risk of cardiovascular or heart disease. So today, if you were to see your gynecologist and ask for a tubal ligation, they would not be removing your tubes, they'd actually be excising the tube completely. The other step for prevention of ovarian cancer for those at increased risk is oral contraceptive pill use. Even 2 years of an OCP decreases the risk significantly of a subsequent diagnosis of ovarian cancer. We don't understand really the etiology of ovarian cancer, but in mammals, there's no other model for ovarian cancers. In chicken and hens that lay eggs, that's the most common cause of death is ovarian cancer. And the majority of hens actually die of ovarian cancer, and incessant ovulation is one of the theories. And so that's how an OCP, in theory, we don't understand completely, potentially decreases the risk of ovarian cancer. Environmental factors surely play a role. The biggest example, and there have been medical legal class action lawsuits related to J&J and talc. Talc often was used as a dusting powder on the vulvar skin or on babies' diapers, and talc sometimes has asbestos in it. Asbestos is a known carcinogen, more commonly known for lung cancer and mesothelioma. But within what we call psammoma bodies, which are calcifications in tissue that we see in the peritoneal cavity in women with ovarian cancer, with electron microscopy, it's been shown that asbestos from talc is in the body cavity. You know, in women, that entry into that body cavity is there from the vulvar skin, vagina, cervix, uterus, out the fallopian tube, ovary, and into the peritoneal cavity. So that's an environmental risk factor, and talc obviously should be avoided. You know, one of the pioneers in genetics and a very famous woman who you may or may not have heard of is Mary Claire King. She was awarded the Presidential Medal of Honor by President Obama, for discovering the BRCA1 gene in the 1990s and then the BRCA2 gene. At that time, it was only thought roughly 5% of ovarian cancers were genetic or hereditary in origin. Currently, it's up to 20% based on our further understanding of the genetics of this disease. What's different between ovarian cancer arising from an inherited gene mutation versus a sporadic case, what we refer to as where we don't have an identified gene source. When a patient has a genetic predisposition, there's often multiple family members affected, and the age is approximately 10 years younger than the average age of ovarian cancer, which is 56. There's a wonderful movie called Decoding Annie Parker. It tells the life-affirming story of two remarkable women and Annie Parker, who was a 3-time cancer survivor, and the geneticist Mary Claire King, who discovered the breast cancer gene, which is really one of the most important discoveries of the 20th century. If you go back to your biology and science class, just to make a point of the distinction between what is a germline mutation and what is a somatic gene mutation or an acquired gene mutation. BRCA1 and BRCA2 are the most common genetic causes of breast and ovarian cancer. The other genes listed can be grouped and called sort of BRCA3, but the list continues to expand. Inherited genes come from both parents, so you can inherit your risk of ovarian cancer from your father, which some people find to be a surprise, but your genes come equally from both parents. In a somatic gene mutation, the most common one in ovarian cancer is one called TP53, and it's present in more than 50% of ovarian cancer. Unfortunately, there's not a molecular target for that at this point, but understanding the genetics of cancers does sometimes allow us to identify targets and therapies or drugs that would work better based on that. And it's a very active area of research to find better ways to treat ovarian cancer. So at this point, we're going to take a poll because there's tests involved in this lecture. So if you're participating, you can click on to answer this question. So which of the following is false related to ovarian cancer? And you have one choice. So you have to think about it a little bit just because the false is there, and that's how they always would try. If you go too fast, you get that wrong. So what's true, what's false? We'll give everyone a minute just to think about the questions. So in case it's hard to read, all the choices are: there's no effective screening test for ovarian cancer in the general population. You cannot inherit ovarian cancer from your father. Surgical removal of the fallopian tube decreases the risk. Early detection is associated with a very high cure rate. While we're waiting for the poll, I just wanted to highlight that often women think ovarian cancer is a hopeless situation. If we could only move ovarian cancer from being diagnosed late, where we call it stage 3 or 4 disease, and 70% of women, unfortunately, are diagnosed at the later stages. It's the minority of women that get diagnosed at stage 1, but the cure rate's 95% survival at 5 years compared to 45% at stage 3 or 4. So again, that highlights the importance of early detection in cancer in general. The earlier you have a symptom and the earlier you seek treatment, the more fortunate hopefully you'll be in arriving at a diagnosis and a treatment plan that would be curative. So the majority of you say you cannot inherit ovarian cancer risk from your father, and that is false. Good. I'm very glad, because it's really important to understand that difference. Some people completely discredit the paternal side of the family history. If you were to choose to have genetic counseling, you would be if you choose to have genetic testing, you would refer to a genetic counselor who would go over all the risks and benefits and document your family tree. So the next topic will be uterine cancer. Of all the gynecologic cancers, uterine cancer is the most common, but unlike ovarian cancer, it's often diagnosed early at a stage when it can be curable just with surgery alone. The symptoms of uterine cancer relate to abnormal bleeding. So bleeding between periods, any postmenopausal bleeding, pelvic pain. The average age of uterine cancer is 61. If you look at the diagram, the very red middle part is the endometrium, or the lining of the uterus. When people say uterine cancer, the most common type is endometrial cancer arising in the lining of the uterus, which connects with the cervix to the vagina. And so blood, if it occurs from a tumor there, is going to be seen and recognized by women as something that's abnormal. There is no screening test for uterine cancer, but recognizing the symptoms often will result in the correct diagnosis and proper evaluation. Your risk for uterine cancer is increased by obesity, early puberty, late menopause, and infertility with polycystic ovarian syndrome. I'm sorry, just one second. Do you need me? I'm sorry. All right, so medications can also cause uterine cancer. For hormone replacement therapy, many women are taking estrogen, but if you still have a uterus in place, then you have to add progesterone. The estrogen unopposed is a significant risk factor, and if you choose that, and women do choose that for some reasons, they don't tolerate progesterone. Progesterone has been associated with an increased risk of breast cancer. Then you should consider having annual endometrial biopsy and certainly be aware of any abnormal bleeding for which to present to your gynecologist for further evaluation. So uterine cancer is the cancer most associated with obesity. I don't have a pointer on Zoom that I can use, but if you look at the graph to the right, you can see with increasing body mass index, and that's often how we measure obesity. It takes into account a person's weight and height. It's not a perfect measurement, but it's an easy measurement to calculate and a little more accurate than weight alone. But that you can see that once you get to a BMI of 30, there's a really sharp increase in the rate of uterine cancer. And for every 5 increase in BMI points, your risk of uterine cancer increases 50%. Obesity affects women much more than men. The ratio is 3-to-1. Part of the pathophysiology or explanation for that is fat cells increase estrogen levels. Obesity is increasing in the United States. Between 1988 and 2016, there was an increase in uterine cancer in all age groups, even in young women under 40, often affecting women even before they had an opportunity to have their children. Between the ages, in young women less than 45, there was a 14-fold increase during this time interval. The largest increase, however, was in women between 45 and 54, which was a 63-fold increase, going from 0.2 per 100,000 to 12.6 per 100,000 in 2016. In older women, age greater than 55, there was also a remarkable increase of 50-fold, going from 0.6 to 30 per 100,000. So BMI can be difficult to measure, and sometimes when I was interviewed for my book, people would argue about BMI and how it's inaccurate and how BMI didn't really reflect the health of the patient or their health of the person. But obesity is considered a disease, and obesity is the #1 uterine cancer associated, but there are 13 other cancers that link to obesity. And more importantly, of the women that we treat for uterine cancer, they're actually 4 times more likely to die of cardiovascular disease than they are of uterine cancer. And that's because of overlapping comorbidities. So women with uterine cancer often have diabetes, hypertension, and that, along with what we refer to as metabolic syndrome, can dramatically increase the risk of heart disease. So if you know that, then obviously there's some changes in motivations there that you could implement to decrease your risk. What's important to remember too is in women in the perimenopause, often abnormal bleeding occurs related to hormonal imbalance, but there are guidelines that your doctor should follow. As a GYN oncologist, where I see people sometimes after they've been diagnosed or have had symptoms that have been missed for a while, in retrospect, it's always easier. But I often see young women under 30, in their 30s or 40s, that have abnormal bleeding, which is attributed to side effect of a birth control pill. Because it's quite common for some women to have what we refer to as breakthrough bleeding or spotting while on a birth control pill. Any woman under 45 who has a BMI of 30 with abnormal bleeding should have endometrial biopsy. And so if you go to your doctor and you have that risk factor, you can ask if they don't offer. It could potentially save your life, because abnormal bleeding, it's impacting your everyday quality of life. So why not find a treatment that works and make sure there's not an underlying cancer diagnosis? Again, when is bleeding abnormal? Any bleeding after menopause, bleeding after sex, bleeding in between periods, excessive menstrual bleeding. The diagram just shows an office tissue biopsy called a PIPEL. It's done as an office procedure. The tiny catheter, it's only 4 millimeters in size, passes through the cervical canal into the uterine cavity, and then with suction removes cells that the pathologist will use to make a diagnosis based on a tissue sample. So as a gynecologic oncologist, I get to operate, which I love. And what's remarkable in the 30 years that I've been, since I started as a resident, is the change in surgical technology. So we no longer make incisions that are large. There are some exceptions, but I would say 85% of the surgery due on uterine cancer at this point is done by a minimally invasive approach. And first that started with laparoscopic surgeries. The first laparoscopic total hysterectomy was done in the late 1980s. And then subsequently robotic surgery came in and was introduced here at Lahey in 2007. For many women, they don't have access to minimally invasive gynecologic surgeons. And so if you're diagnosed with uterine cancer and someone is recommending an abdominal surgery, you can always ask if minimally invasive surgery would be appropriate. There are some reasons women may not qualify. But if you look on the picture on the left, you can see that minimally invasive surgery is done through tiny keyhole incisions. And those incisions dramatically decrease the chances of you developing a postoperative wound infection. In many of our uterine cancer patients, because of elevated BMI and the comorbidities of diabetes, they are quite high risk for skin infections or abscesses related to the surgery procedure. It wasn't uncommon that we would have uterine cancer patients readmitted in the ICU due to abscesses and sepsis after surgery in the setting of morbid obesity and diabetes. So minimally invasive surgery has had a huge impact on the morbidity of the surgical treatments that we offer. When many patients will ask me what's the difference between a laparoscopic and a robotic approach to surgery, the access is the same, it's just the instrumentation is different. If you look at the photo with the grape, you can see that the instrument is jointed at what we would call the wrist. So if you look at my hand, a laparoscopic instrument can go in and out and it can rotate on its axis, can open and close, but it can't do what the human wrist does. So a robotic instrument allows my hand to do the same thing through these instruments as it being actually inside the body cavity. So you can operate in a very tight space and not require any incision other than these small 8 millimeters incisions for the instruments. And so then you may ask, well, how do you get the specimen out? And we remove the specimen intact through the vagina. Oh, sorry, I should have warned you. This next photo is a operative photo, and I wanted, some people may be eating lunch and might not want to see the surgery, but the next slide is a movie of a new technique that's been part of the NCCN guidelines since 2014, referred to as a sentinel node biopsy. So part of the staging for uterine cancer is to look for cancer cells outside the uterus. When you look at this photograph here, the uterus is over here. The white structure is the ovary. The fallopian tube is being held by one of the robotic instruments. This patient, if you look closely during the movie, has had a tubal ligation, and you can tell because the tube here is filled up with fluid. Over here on the sidewall, the lymph nodes follow the blood vessels. And so rather than remove all of the lymph nodes, which can cause a side effect referred to as lymphedema, we do often what's called a sentinel node mapping with biopsy. And that is supposed to remove cancer, the lymph node most likely to contain cancer cells representing the entire basin. But it's just the lead node rather than all of the nodes present on the sidewall. So the movie hopefully will play here. And you can see that the infrared camera allows us to see things that we can't see with visible light. So the robotic camera has a toggle switch that you can go from visible light to an infrared light that fluoresces this medication called isocyanide green, or ICG. You can see the afferent pathway or the highway of the lymph vascular system to the regional lymph nodes. And the surgery here shows us on the sidewall. Here you can see your external iliac artery, the main vessel to the leg from the pelvis. And then this is all fatty tissue, and we don't actually see the nodes in visible light. The lymph nodes are embedded in the fatty tissue. But if we have the technology where we can use an infrared fluorescent molecule, the ICG, we're certain that we have an adequate lymph node sample, and we can track those vessels to the node most likely to represent the remaining nodal basin. So let's try another poll. What is the greatest risk factor for uterine cancer? So the choices are estrogen alone for hormone replacement therapy, smoking, obesity, and nulliparity, meaning a state in which a woman has never given birth to a child or has carried a pregnancy. So this one's a little harder because it's greatest. So some of these are true. There's one that's false. So hopefully no one picks that one. The rest of them are all true to a certain extent. So while we wait for the poll, I'm not sure if it's right there yet, but oh, here we go. Great. So not all uterine cancers are obesity related, but the majority are. And obesity, again, it's not just uterine cancer, it's 13 other cancers. So I'm so pleased with your answer to that question. So we'll move on to our final cancer that we're going to review today. So cervix cancer is from the lower part of the uterus, often referred to as the neck of the womb in lay terms. The symptoms of cervical cancer, they're listed here, but it's really important to know that early stage cervical cancer has no symptoms. By the time you have symptoms for cervical cancer, it's often advanced and not amenable to surgery, which is why it's so important. This is the one cancer that women have, reproductive cancer, that has a proven screening test, a pap smear or HPV testing, and there's various protocols for testing based on your age and preference, but screening prevents cervix cancer. It's dramatically decreased since the 1960s when Papa Nicolau, who the pap is named after, collected cells from his wife and looked at them under the microscope and realized that you were able to, over time, understand the cytology of the reproductive tract and distinguish normal from abnormal. The symptoms that do occur that's specific to cervix cancer is often postcoital bleeding or bleeding after sex, bleeding in between your periods or spotting, postmenopausal bleeding. The bleeding for cervix cancer is often light and it's not heavy like the bleeding you would get for uterine cancer. Vaginal discharge or odor, urinary frequency, constipation, pelvic pain, those are all symptoms, but they're quite late in the diagnosis of this cancer. What's important to know that human papillomavirus is associated with the majority of cervical cancers. There are very many different strains of HPV virus, the HPV virus, more than 100 at this point. The high risk strains have a vaccine and are incorporated into the vaccine. HPV related cancers include cervix, vaginal, vulvar, anal, and oral pharyngeal. So the risk factors for cervical cancer, the strain of the virus matters. 16 and 18 account for more than 70% of the cases of cervical cancer in the US. The age of cervical cancer varies more so than the other two cancers we discussed. It often is most commonly diagnosed between 33 and 40. There are no cases of cervix cancer reported in women under 21 years of age, which is why the guidelines got changed, because women often were getting pap smears when they first became sexually active at 18. But we know the natural history of HPV infection. It takes different models, but it's estimated 5 to 10 years from when you're exposed to HPV to when you potentially would develop a cervical cancer. There is still risk in the older ages. At age greater than 65, we still see about 20% of cases, but those are in women who have had not completed screening. If you were following guidelines and having a pap and HPV test after age 35 every 5 years and it's always negative, your risk is really minimal. And pap smear screening, or pap and co-testing, we call it, pap and HPV, is often discontinued at that point. Smoking increases the risk of cervical cancer. There are carcinogens in cervical smoke that end up secreted in cervical mucus. HPV plus smoking together greatly increases the risk. And then immunosuppression is a factor. Some women will develop HPV-related genital warts, dysplasias, or cancers later in life when they haven't been sexually active for years. And part of that is just the aging and weakening of the immune system. Transplant patients commonly will have cervical dysplasia. If you're getting a transplant, part of the protocol is to get an HPV vaccination before you get the transplant because of the impact of immunosuppression, the immunosuppressive drugs needed to prevent rejection. And steroid use, again, it's another immunosuppressive agent. This slide is a little busy, but what it shows you is the rates of HPV-related cancers by age. In women, the majority of the average age, or median age rather, of cervix cancer is 50. So 50% of the cases are recurring less than 50, and the other 50%, it dramatically starts to drop up, are in the older age groups. The other cancers are much less common, with vulvar cancer, anal cancer, oral pharyngeal, and vaginal cancers shown on the graph, with what happens in women is on the left, and in men, you can see on the far side, obviously they do not get women's reproductive cancers, but there has been a marked increase in oral pharyngeal cancers, and more men develop oral pharyngeal cancer than women develop cervix cancer at this point. So it's important to know this. And initially, when HPV vaccination programs were introduced, they were introduced to women only because men don't have a cervix, would be the reasoning why. But we all know that herd immunity matters in how contagious and how we're able to control viral infections, and that gender really doesn't matter. When you do have cervix or exposure to HPV, it doesn't mean that you're going to develop cervical cancer. In fact, the majority of people are healthy and have immune systems that clear the virus. The real risk is persistence of HPV high risk types over time, and the virus gets integrated into the DNA of the cells. So cervical cytology or pap smear results can go from normal to cervical cancer, reflecting different degrees of severity. In young women who have HPV or low-grade SIL is what that stands for, cervical intraepithelial or squamous intraepithelial lesion. If you wait 2 years, the majority of those abnormalities will resolve on their own with no intervention. This is a really important slide because it shows the age of vaccination relative to the cumulative incidence of cervical cancer in the population. And this is a cohort study from Sweden where they had subsidized HPV vaccination in place initially for girls only, but it was extended to include both boys and girls. And the program was incorporated into school programs, and school nurses were doing it as part of the protocol in that country. So you can see the difference in the graph. The unvaccinated orange line has the highest rate of cervix cancer relative to the green line. And vaccination is most effective if given before age 17. There is an 88% decrease in the incidence of cervical cancer in women vaccinated in this study. So the final question in this test is HPV vaccination is associated with blank. While we're waiting for the poll, HPV vaccination, if given in the younger age groups, only requires 2 doses of the approved vaccines, whereas if it's given in the older age groups, 18 to 26, it requires 3 doses. Recently, the FDA extended that upper guideline to age 45, which is part of the reason here. So, right, correct. That's the take home message. And, you know, there's a lot of beliefs around HPV vaccination, and does it increase my child's sexual promiscuity? There's many women that come to see me that have high-grade cervical dysplasia, a precancerous lesion, that have never been vaccinated, and they sit in my office and they tell me they're not at risk. They're at risk. You need to know your risk. If you're a woman and you're sexually active and you have a cervix, you haven't had a hysterectomy, you're at risk. And this is a very simple vaccine that's effective with few side effects. So what can we do as far as our own health to live healthier lives and avoid a cancer diagnosis altogether? So make sure that you schedule your cancer screening tests. We focused on reproductive screening here, and the only test that we have is the PAP and HPV. And it can be confusing because there are 3 different societies with different guidelines. But the important thing is to understand that HPV is related. If you are HPV positive, it does not mean that you are going to get cervix cancer. It depends on the strain, it depends on your immune system, and it depends whether you go for screening. And if you have abnormal pap smears or dysplasia documented, if you go for the follow-up and treatment. By treating the abnormal paps, we eliminate a lot of risk for women. HPV as a primary screen is now recommended by the American Cancer Society starting at age 25 with no pap smear. It's very hard to convince women sometimes not to have the pap or to do a pap plus HPV is an option. But often the people that need the screening test most are those that have never been screened. Another error that sometimes occur is that you can have an abnormal test result, but you didn't check with your doctor. Your doctor wasn't able to get in touch with you to go over that abnormal test result. So be proactive. Make sure your test result, you've had the test, make sure you know the result. The second most important thing is body mass index and obesity because of the risk of 13 other obesity-related cancers. I think we more or less went over that. And then finally, I think it's really important to exercise. Exercise decreases your cancer risk. There are guidelines by the American Cancer Society for exercise. You can look up, they're a little bit hard to apply on a daily basis. But a new article came out that sort of translates into modern language of 10,000 steps a day. A lot of people are able to have watches or iPhones or things to track their steps. And this is a nice goal to set. If you don't set an exercise goal, it's very hard to achieve it. When I ask women if they exercise, they say, yeah, I take care of my kids, I do the housework, I do this, that, and the other thing. But that's not the same as taking time for yourself and doing something that you enjoy, that you know is healthy and will enable you to improve your own health and hopefully avoid a cancer diagnosis. Only 17% of Americans actually meet the American Cancer Society guidelines for exercise. And finally, 4 and 5, the importance of vaccination. So HPV vaccination. The National Health Interview Survey demonstrated, self-reported, that HPV vaccination rates have increased in women from 26 to 35% from 2013 to 2018, and men from 2 to 9%. So that's nowhere near any herd immunity. And it's such a simple, easy thing to do. It is covered by most insurances up to 26. The recent increase to age 45, discuss it with your doctor if it's not covered. If you've already been exposed to HPV, it will not treat HPV or cancer that's already there, but it will prevent exposure to other strains that you may not have been exposed to. And besides preventing cervix cancer, it also prevents genital condyloma, which are warts that occur in the outside skin of the vulva, sometimes in the vaginal area and in men as well. And they can be very distressing to young women for the cosmetics of it, and often end up with treatments such as laser or cryotherapy to get rid of them because they can cause irritation, itching, burning. And then finally, I think it's really important to consider genetic testing if you have risk. And if you don't talk to your family, if you don't talk to your relatives, you may completely miss out on an opportunity that would have a huge impact on your personal cancer risk. So as a GYN oncologist, I do wear many hats. One of my favorite things is really to advocate for women to take care of themselves and do the things they love most. I was fortunate the other day, one of my patients said I could share this with her. And in my book, there's a chapter about a woman who wants to play tennis, but she gets diagnosed with a big ovarian tumor and wants to have minimally invasive surgery because she was on the tennis circuit, a very talented athlete. So I was so pleased that she came in the office the other day and she gave me her hat that she won for being first runner-up in a local tennis tournament. So there's nothing could make me more happy. And then on the far side, a gift from one of my patients. And if you wear this in the ski hill, people will ask you what it is. And you do get an opportunity to talk about tubes and ovaries, which would never otherwise come up. So with that, I would like to end. I'm really thrilled to be here and to be able to share some of what I've learned by being a physician. I'm very privileged to be a physician, to have the education I have. And I hope that you've listened and learned things that will allow you to speak up and get the care that you need. You know, if you've read my book, you'll know that my older sister passed from ovarian cancer. And I really don't think you should have to have a sister that's a GYN oncologist to prevent cancer in other family members. So we need better advocacy. We need screening tests for the cancers that we don't have screening tests. And I hope all of you are able to get the care that you need. I know that it was a passion of Kathy's to improve healthcare for women and to empower women to take charge of their own health. So.
Hi, Valina. Thank you so much for an incredible and informative presentation. We've gotten a lot of questions and we're not going to get to all of them today, unfortunately. So I'm going to edit. So what progress has been made in regards to early detection?
So for early detection, what's fascinating, it's not FDA approved yet for screening, but a liquid biopsy that made the cover of Time magazine. And a liquid biopsy is FDA approved in diagnosis, but not in screening. What a liquid biopsy is, it's a test done in a sample of blood to look for cancer cells from a tumor that are circulating in the blood, or pieces of DNA that have broken off from tumor cells. It can help find cancer at a very early stage. Right now, it's being used to monitor treatment and to detect recurrent cancers early. There are some companies that offer the tests. One's called Grail, but it's expensive. It's about $949 for a test, and the company recommends it once a year. The problem with some of these tests, and the same discussion came when BRCA gene testing was first introduced, is there are probably some false positives, and what do you do with that information? We don't want to overtreat people and cause disease, especially when someone is healthy and well. We want a screening test that's accurate and is has a very low rate of false positive test results, because the consequences of acting on those results are significant.
Great. So next question. What's the one thing you would recommend to all women to help in the prevention of cancer?
I think the most important thing is to believe in yourself, to know that when you have symptoms and you know it's not normal, not to ignore them, to speak up and talk to your doctor. There's ways you can talk to your doctor politely. If they disagree or you disagree, you can always get a second opinion. But I think a lot of times women's health issues don't receive the attention they deserve, and women are dismissed. We have lots of documentation of that. I think my favorite one is one of the late night hosts that quoted an article about women calling 911 for heart attacks. And they looked at the ambulance ride to the hospital. And for men, the siren was turned on, but for women, it wasn't the majority of the time. So how do women speak up so that they're heard? I think that's critical for women to be able to improve their health and get the treatment that they need.
Perfect. So I want to thank you, Valina, and all your colleagues for everything you do every day to keep us all safe in your care. We know this hasn't been an easy time for our frontline providers, and we're enormously grateful for your efforts to keep us healthy, and of course for joining us today when I'm sure you're really busy. Notice the guy walking in and asking you questions. A special thank you to all our guests for joining. Should you have any questions from anything you've heard today, which because we're running out of time, I'm not going to answer them all. We'd love to hear from you. Please feel free to contact us at 781-744-3333 or by email at philanthropy@lahey.org. We urge you to join our fundraising efforts to support Kathy Huber Fund at LHMC. And you can make a gift online, and you can use the little QR code. Thank you, everybody, and have a fabulous day.